mobilization tools that we can use for our pediatric patients. So we talked about the Pigastat, the Tamon board, the Infantainer, Positop were some of them. So again, make sure you are just familiar with some of those names. We can also use sandbags to an extent. Sandbags are nice and soft and do not hurt the child typically. I looked at this picture, and one thing that I learned, I've gone to a couple conferences, seminars on pediatric radiography, and one of the things that they recommend is when you're putting a sandbag on a child's legs, maybe just to hold them still. It won't immobilize them, but it'll help maybe if they're cooperating, it'll help a little bit. Certainly this patient wouldn't be old enough, bless you, to maneuver out from underneath there, but notice that they have a sandbag or something underneath their knees. And I think this is important, and you can imagine with your legs straight, if something was laid over your knee area, that would force the knee back, and I would think that that would be uncomfortable, especially a heavy sandbag on a pediatric patient like this. So they recommend putting something under the knees to support the knees and then put the sandbag on top of that. So little things like that make a big difference with the success of your exam. It's like if the child's already not feeling well, and then now we're adding to that, and I told you about me holding the patient, things like that, these things that we need to kind of think about to make it a little bit better for our patients when they can't tell us, you know, all they do is cry and we don't know why. Are we hurting them? Are they already hurt? So they can't communicate with us when they're that young. So anyway, I wanted to show you that picture so that you can think about that when you're using those sandbags for support. Again, you know, if we're doing a chest x-ray, this is fine, you know, close to collimate, but look how the edges of the sandbag are close to the body part. First of all, they are artifacts, they will show up on the image, so be careful with that. And second of all, if they're close enough, maybe they're out of the anatomy, but in your radiation field, in your light field, they will attenuate the beam and it will skew your S or EI number, whatever you're using, your exposure index. So make sure that they're out of the way and out of the light field. And I think I showed you this picture before with the little, I have some pictures of a pediatric hospital. I don't know that they're all like that. I haven't been to CHOC or to CHLA, but I would imagine they have some sort. A couple of the hospitals I trained at or worked at, they had a floor. One floor was dedicated to the pediatric patients. Do you have anything like that at your hospital that you know of? No? Okay, so and the one floor that we had at one of my hospitals, you know, had things like this, and the lead aprons had the smiley face on it. You know, they weren't just the dull blue that we have or whatever color. You know, they were a little bit more child stuff, and they had appliques on the walls of animals and just fun stuff for the kids. So we'll talk a little bit more about that. Ace bandages are always good, or any stockinettes. They're nice and soft. They're firm. You can put them on tight, again, without hurting the patient. Just make sure that if you have any of the brads, you know, the little clips, those will show up in your image. So make sure that you don't have those on there. So those are a nice thing to have for your pediatric patients. And then tape. This kind of upsets me. I don't particularly like this one. All tape does is going to help hold them still if they're cooperating. If they're cooperating. So sometimes kids want to help, and have you seen this where maybe if you have kids, they want to help, but they can't. They're just little wiggle worms. They just can't hold still. You know, so a piece of tape or something like that, or a sandbag on their arm may help them hold still if they're cooperating. If they're not cooperating, as we've talked about before, where they're just fighting you, tape is not going to be helpful in that case. So here they've got, I'm assuming that this is going to be a skull image. They've got her mummified and secured, and then her head is on the sponge. I have used tape to help the patient hold still. A couple of things about this picture that you need to be careful about. Make sure you're using the right kind of tape, and the kind of tape that we probably at your hospital is appropriate, but just make sure pediatric patients, young ones, have very delicate skin, and we wouldn't want any tape that would bruise or irritate their skin. Thank you. So what I do, and this doesn't always work, but I use the tape, but as I bring it across, I twist it right here so that the sticky part is not touching their skin, and then bring it across and then twist it again to the other side of the table, or in this case of the device. Can they still move? Yes, that's what I'm saying. It's not going to, if they're fighting or they're turning like this, it's not, even this probably wouldn't work. The other problem I have is the hair, being on that. And the chin is a great place. The other thing you can do is maybe get a piece of gauze and put it underneath there as you bring this across. Not my favorite. This is certainly okay. Again, it looks could kill. This is holding her arm still. She's cooperating, and we just want to make sure her hand is supinated and that sort of thing. So, it's lightly placed across just to make sure she holds still. In this case, here's what I would personally do. If this was a skull, I would just put on a lead apron and hold. Now, you don't do that as students, but as a tech, I can control the patient better, and the way I do it is typically with the chin. You can bring the chin down, up, or to the side, not be in the way of the skull. Yes, sir?
Why would you hold and not have the parents hold?
Because it's a skull, and now that you've had skull positioning, how important it is to keep the OML perpendicular, MSP, and I think a parent
they won't know what to do.
Wouldn't know what to do in that case. It's not like a chest x-ray, just hold the arms, or hold the arms here and the legs here. That's pretty basic, and the patient lays flat. But just for skull, the other thing that I've done, and I think I talked to you about this last time, getting two thick pieces of sponge, and I'm talking thick sponges, and you can put them up next to their head and control their head with the hands being way out here. And you can push fairly hard like this and not hurt the patient. So the thing about pediatric patients that we do different than adults is a lot of times we'll have a limited study. So instead of doing a 4V skull, right, the AP or PA, both laterals and the towns, right, that's a skull routine, we might just do one lateral. And so we try to limit the number. And with pediatric patients, what do we always want to avoid?
Motion.
Motion and repeats. So holding has always, I've done a lot of these. You're not doing as much as these exams as I did. And so to get it right the first time, to minimize our time in there, put on a lead apron and do it. I'm not saying that's the best way. That's typically the way I handle it.
So for most adults, for like skulls, they just send them to CT, right? Is it the same for pediatrics, or they prefer X-rays for skulls?
What I have found in my experience and what I've seen is that, remember the days, well, you don't.
Tell us.
The days were when a child hit their head, when they fell. I mean, how often does that happen? You've had children, how often did they fall and hit their head? And they get that bump, that egg bruise thing, and they would take them to the doctors to make sure the skull wasn't fractured. Well, the skull might have been fractured. What are they going to do about that? If there's a hairline fracture, let's just say, what are they going to do about that? Nothing. It's just going to grow back. In fact, a lot of kids do fracture. It may be a little, not a depression fracture, or, but a confusion, right? But it would just be a hairline fracture, and it would just grow back. I mean, the main thing is that we want to make sure with the CT exam that there's not any bleeding in the brain or anything like that. But every kid who would fall and hit their head, mom and dad would, of course, be concerned and bring them to the hospital. And we would do a skull x-ray on them. So that's what I'm saying. I did a lot. Nowadays, and I've been in the hospital in the ER, and the child next to me had the bruise and had fallen, and The doctor, the mom was like, don't we need some x-rays? And the doctor's like, no, we're not, I know how the child, you told me how the child fell, how far they fell. There is a huge egg bruise swollen on their forehead. And the doctor said, no, we just watch to make sure that, that pupils dilate appropriately and all that sort of stuff, and observe for 24 hours, just observe the child, make sure they're not throwing up, that sort of thing. Sent them home. I'm like, oh. And my sister did, I have it recording. I'm recording my nephew playing and standing up on this wheeled device, and he went right over and bam, right onto the concrete, and we didn't take him to the hospital. And maybe we should have, now that I'm thinking back. No, but they just, even if you take them to the hospital, and I'm not saying you shouldn't, you should, but they aren't so quick to do x-rays, and certainly not CTs unless they suspect some sort of brain injury. So they're just not ordering them like they used to. Oh my gosh, on skull x-rays, I would get requisitions that said headache. Headache. And so
take an aspirin.
And it's like, you're not going to see anything on a skull x-ray that would, have anything to do with a headache. That's a CT scan or an MRI scan as far as I'm concerned. But that's what the old way, the other thing about the old way of ordering exams, and I may have talked to you about this, or maybe Dr. Ferneza, was I'm having abdomen pain, upper right quadrant. Okay, so you've got an IVP for kidneys, upper GI, barium enema, and an ultrasound of the gallbladder, maybe even the oral contrast for gallbladder, and then get all those results, and then the doctor would decide what was wrong with you and go from there. So it was a battery of tests done and then a diagnosis, as opposed to now, what do? We do a test, look at the results. Don't have it, maybe do another test and go like that. So it's quite different back in the days. Not the 1850s, but the 1980s, certainly different. So again, make sure it's a masking tape. Do you know what masking tape is? It's the same thing as autoclave tape that they use for sterilization or any of the hypoallergenic types of tape that you have in your department. So just make sure it's nothing that's adhesive. And again, the adhesiveness will be too much for the skin and also show up. You want duct tape, let me tell you, when you're fighting, you want that duct tape, just get that out and tie them up with it, but that's not going to work. And then we have, and I talked about this before, here we have the head clamps. Notice how it's attached to the table, and then you've got these little padded clamps. The padding there seems really thin to me, but maybe it just looks that way after it's tied against the skull. Here, this picture always bothers me. So here is a compression band. Again, this is attached to each side of the table. This is opaque and this is lucent. I call this like visqueen. It's like a plastic. And this is great. You attach it to each side of the table, and it's on a roller. So you attach it on the table, and then you can roll it and tighten it. And again, it's over a large area, so it doesn't hurt the child, even when it's tight. So again, this type of patient would work. Your 3 or 4-year-old, 5-year-old who's fighting you, not going to work. They'll be able to pull their arm out from under it. So these are limited in use. Here they're using it to secure the bottom part of the patient. Again, notice how she is holding the body of the patient with more like her forearm even has a pillow there to help. Now does anything strike you funny about this image? Look, the little baby, right? And then look at,
That is a long baby.
I know, that bothers me. Look, but how cute are those little shoes, right? But it's like, are the legs that long? I don't know what's going on there. So, anyway, notice again how they secure the bottom part of the body, because if they're fighting with their limbs moving, that's going to move the skull. So we can mummify, and we'll do that in lab today. I've never swaddled a baby with a blanket. We'll teach you how to do that. You swaddle them, and then you can even put the tape around that to make sure it secures them for that. These are my favorite. I think somebody in here has used these before. These are very heavy weighted blocks. See how thick those pads are? You can really push these up close to the patient to where they can't move too much. And then you've seen this picture before, and that's what I was talking about, her using the weight of her body and her forearm to help hold the bottom part of the body still. We'll look at skull x-rays of pediatric patients. There's a couple of things that you'll notice. The head is much bigger than the face. And then don't forget they have 2 sets of teeth. They're, and so they just look, they're just full of teeth. And so when you want to do that Waters view for the sinus, when you bring their head up, guess what goes right into the sinuses? The teeth, the permanent teeth. So anyway, we'll look at that here in a second. The mummifying is up to 2 to 3 years of age. We'll do that in lab today and show you how to do it. So let's look at some bone development. I love, when I first saw pediatric images, it cracked me up. It's like, what's holding that body part together? I mean, like the wrist, some are even, what happens is it's all cartilage. Cartilage doesn't show up on an image, on a radiographic image, until later when it starts to ossify. And so a real young pediatric patient, these will be little dots, and it's like, what is holding their hand together or whatever? So it's pretty funny to see. But they haven't completely developed, and so you'll get these. They're epiphyseal plates. Their epiphyseal plates have not ossified yet. So it looks like a fracture. Sometimes it looks like a fracture. So looking at the bone, just to review, this is the secondary growth is the epiphysis, the primary growth is the diaphysis, or the shaft, and then the epiphyseal plate is in between. And until they're about age 25, that will, about 25 will solidify, or ossify, excuse me. So, so a lot of times, at that being the case, again, same thing here in a pediatric patient. What does that look like? If you didn't know any better, that could be what is a fracture?
A Cole's fracture?
A Colles or
a Smith?
A Smith, yes. Colles or a Smith fracture. I mean, you just, knowing they're a pediatric patient, you get that, but could it be? I mean, how would you know? So a lot of times, have you had this situation where the radiologist wants the other normal body part? So let's say they hurt their left elbow, they also want the right one for comparison purposes. Have you had that experience yet? Was that, tell me, was that ordered? What was the situation? Did it say right and left elbow as an example?
No,
or?
it just had it for the right, but then they called and asked for the left.
Okay, so while the patient was there, or did you have to go back and get the patient?
Normally with the pediatrics, we try to call them right away.
Okay.
Just so that they don't even have to come back.
Right.
And
I
it's
think
at the hospital.
that's good. So see, again, with me growing up in radiology, if a pediatric patient came in left elbow, it was automatic to do the right for comparison purpose. That was a standing order. So now it's not a standing order anymore, but typically they'll want something like that. So either call it in, find out what your protocol is. But a lot of times, especially elbows, some are easier than others. And so they can compare. If the other elbow looks like that, then probably it's just the way the child is. And if it's different, then they can determine if it's a fracture or not. So see what I'm talking about? Like, what is holding that leg together? It looks like it's just funny looking. So, 1-year-old to a 12-year-old. So it says ossification is complete around age 25. Some could be earlier than that, but usually by age 25 it's complete. So what do we do for our radiation protection? Minimal repeats, gonadal shielding, our short exposure times in the close collimation, as we always have talked about before. So here's just some cutouts that can be used. Lead gloves work well. What is the minimum amount of gonadal shielding?
0.5
0.5 millimeters of
lead equivalent.
lead. So the parent, this one is, it's real easy for me to critique images, right? I'm real good at critiquing other people's work. So if you're gonna have the parents come in and help hold, which is always good, make sure they have the lead aprons. If their hands are gonna be near the field, and this would be for anybody holding, you'd wanna have the lead gloves. However, it looks to me like they're doing, maybe, I don't know, I don't see a light. I don't know if they're doing a lower leg or not, but if they're doing a lower leg, do you not have to include both joints, knee and ankle? So this concerns me right here. So just be aware of how your lead gloves, where they are when you're holding the patient, what to do about this. You can certainly hold the upper leg. You might get a piece of tape for something like that, or just hold by the heel. So just make sure your lead gloves are out of the way of the anatomy that we're trying to image. That's my patient. They all were screamers. Okay, so pre-exam prep, again, as we talked about, get everything that you need ready ahead of time. Remember, if you can expedite the procedure, then that gets the child out of there under that stressful situation for them as quickly as possible. And so get your markers, your image receptors, whatever you might need, any immobilization devices. A lot of times we get people that help us. For a pediatric patient, I might be the one holding, and I might get a colleague to make the exposure, or vice versa, if that's what I need help with. So if you decide to get somebody to help you decide ahead of time who's going to do what, have you ever worked with somebody closely and you think the other person did it and they didn't do it, and it didn't, whatever it might be, didn't get done? Sometimes you've got to communicate and make sure everybody's doing what they need to do. And as I said before, the limited study. So with our pediatric patients, look to see what the protocol is. It may be a limited study. And instead of doing a 3-view hand, they may just have a 2-view hand as an example. So as I talked about before, a 4-view skull would now be a 3-view skull. So a lot of times we can minimize the exam. And then you want to make sure that a pediatric patient, if they have a diaper on and you're x-raying in that area, that would be an artifact. Those do show up. Clothing, especially with our digital radiography, you can even see, I don't know, have you seen any patients' clothing on your images that with digital? It's pretty sensitive. And again, if they're manipulating the density and the brightness and the contrast, then you would be able to see the clothing artifacts. So as with an adult, you would do the same thing for a pediatric patient. So if you do have to prep the patient or gown them, make sure you explain that. And then any shielding for the pediatric patient and of course the parents if they're going to be in the room. So get that ready to go. Don't have the child in your room crying while you go look for something that you might need. Here's what I was talking about. Here's a lead apron with the little Dalmatians on. And then this is at a hospital in Dallas, and they had made just some clothing that instead of putting them into a gown, they put them in these little outfits. So I thought that was cute. And some alternate imaging modalities that we can do. So as you're looking at this, look at some of the things that we do for a patient. Of course, there's other things that can, maybe fit in here, but these are common stuff. So CT is different now. Again, back in the day, we used to sedate our pediatric patients when they had to have a CT exam at whatever age, because even if they were able to cooperate, a lot of times they couldn't hold still for the entire exam. And let me tell you, they weren't the CT exams that you know now. They were long exams, like an MRI. maybe 15, 20 minutes, and now they're much, much faster. So that's been a real boom for our pediatric patients having a CT exam. So much faster, that sedation doesn't have to be performed as much. I'm sure they do still have to sedate some patients, but not like they used to, so we're much faster at that. Of course, we don't want to do a CT, of course, on our pediatric patients unless it's warranted to do, unless it's necessary to do. Ultrasound is a great alternative imaging modality because, again, we're just using sound waves. However, the problem with ultrasound is we can only use it for soft tissue structures. We are better at doing hips. That's, ultrasound does not go through bone. But as a young pediatric patient, their bones are very, have a lot of, they're not as brittle as an adult. They have more water content to them. So it's a little bit easier to examine. So we can do BDH images of pediatric patients. But most of them are going to be soft tissue structures. We do a lot of neonatal heads. So when a baby is born, right, when a baby, it's like, well, I just told you we could do hips, but here we are, skull. How can we x-ray the brain of a pediatric patient for any bleed? So sometimes when during the birthing process, they can have damage to the brain itself or just anything as a pediatric patient, maybe even a fall. We can image the brain through the fontanelles, the openings in the skull. There's 2 fontanelles, so we're able to get a little teeny tiny transducer, put it in that fontanelle and scan through the brain to look for any bleed. So we are able to do that. This is pretty interesting, and along with any shunt tube placement. So these are some of the things that we would do on pediatric patients. So now appendicitis, you can have that in an adult also, but children tend to have that quite often, and we can diagnose that. Pyloric stenosis is when the baby keeps, did you study that in digestive system? Pyloric stenosis is fairly common when the baby takes the milk and keeps throwing it up, and then they start losing weight because the milk isn't going through the pylorus. It's
Constricted, right?
Constricted or stenosed, yes. And so what they do is they go in there and dilate, but that can be seen with ultrasound, with somebody who knows what they're doing. Here's a neonatal head. You can see the increased ventricles. There's increased fluid in the ventricles here. So there's pyloric stenosis. Here's the stricture of the pylorus, and you can see that. Can't you tell? Doesn't that look like a pylorus? That's what I'm saying. With ultrasound, you got to know what you're looking at because it all looks like something. Like, oh, what were we imaging? I walked into the ultrasound class and they had a picture of a thyroid. And I'm like, oh, testicles. Because they looked the same. They started laughing. I knew it was. So again, DDH. Okay, so I'm going to be going through a lot of pathologies, pediatric pathologies. So just what I want you to look at, like when we're doing a chest exam on a pediatric patient, I'm going to have a bunch of pathologies. Just, you don't necessarily have to know what causes them or anything like that, but you just need to know that would be an indication for a chest x-ray, not an abdomen x-ray, for example. Is asthma a reason for a chest or an abdomen? And absolutely a chest. So anyway, here's what DDH is. We used to call it CHD. Again, that's changed. And here's the ultrasound. So that I'm assuming that's the femoral head, and they're pointing to something. I don't know. I mean, is that a muscle? Is that a tear? I don't know. But there's the ultrasound. You have to know what you're looking at, and obviously I don't. But what DDH is, you can see where one hip is not as matured as the other, and so that happens a lot, or is common in pediatric patients. Not always, but mostly. Here's appendicitis. We call it the bullseye. Oh my gosh. And with ultrasound, you have to be careful. If you don't see it, doesn't mean it's not there. So instead of, you had to be careful when we teach our students not to say, oh, it's negative because they didn't see the appendicitis, as an example. Oh, it's negative. No, you didn't see. I did not see this, as opposed to it's not there. So you have to be real careful about that. I had a seasoned tech. I remember I saw him the next day, and I'm there, and he looked exhausted. He's like, oh, I was up all night. Oh, were you called out? No, I laid in bed awake all night, worried about the child that I did an ultrasound on earlier in the day, and I saw the appendicitis, and they took him to surgery. And he goes, I just kept doubting myself all night. What if it wasn't appendicitis? What if that wasn't it? What if I was mistaken and they took this child to surgery and opened him up, kind of thing? So he was like, he goes, the first thing I got to work and read the pathology report.